Disclaimer: the contents of Studio 151 podcasts and the TU Communication Disorders Connection podcast do not represent the views and beliefs of the University of Tulsa and the Mary Kay Chapman Center. Hello, welcome back to the TU Communication Disorders Connection podcast. This is your host, Alyssa Hall, and today I'm joined in our new studio, in-house, with a very special guest, and that is Kim Frey. Kim is director of the SLP department at Craig Hospital in Englewood, Colorado. She also has a dual PhD in cognitive science and speech-language hearing sciences. Kim, it's an honor to have you on the podcast today.
Thank you. It's so nice to be back here. As a TU graduate, I'm just so thrilled to be back here. Long time ago, but things look a little different now. I was here from 1989 through 1992, so I am so happy to be back.
This is like a reunion.
It is, and then my daughter ended up going here as well for nursing school, and she just graduated last year, so keep it in the family. It's just a great place to learn and grow and just have really some of the best years of your life, I think. So
I completely agree as someone in my second year here at grad school.
Yeah.
So I know that some of your research, your special interest, your clinical practice has to do with strokes and people with aphasia. We can think about that both as an SLP and just a person interacting with people with aphasia. As a communication partner, what are some things you can do to support the other person in conversation?
For such a great lead-in, Alyssa, I think such an important question. In fact, this is pretty much the topic of my presentation tomorrow at the Tulsa Neurotrauma and Stroke Symposium. The gist of it is really we communicate for certain reasons, and we as communication partners need to provide and create those opportunities for communicating, especially for people who have aphasia, who their default tends to become learned non-use because talking is hard. So it's really up to us as communication partners to create those opportunities for communication. We do a lot of co-treats at Craig, so physical therapy, occupational therapy, neuropsychology. We also have a program called our Neurobehavioral Disorders Program, which is a group of folks, all who are either board-certified behavioral technicians and registered behavioral technicians. And so these are people who are often called in to work with our folks who are agitated, might be aggressive, have some neurobehavioral issues that we need support with in order to be able to work with them in their therapies. And so we're working a lot with that group.
Some clients with behaviors that can at times be kind of aggressive. Is that one of those differences you might notice between post-stroke and post-TBI people with aphasia?
Great point, yes. I would say more so probably we see challenging neurobehavioral characteristics and qualities in our folks with traumatic brain injury than we do with stroke. So I think in terms of agitation, restlessness, whether it be verbal restlessness, physical restlessness, verbal agitation, physical agitation, those are definitely seen in our folks with traumatic brain injuries. The converse of that we also see in our folks with stroke, as well as in our folks with traumatic brain injuries, is kind of this neuropsychiatric condition that we would consider like apathy. So decreased initiation. So you've either kind of got too much of something or you've got too little of something. And so we're really trying to create communication opportunities in both of those spectrum, or both of those bookends, if you will, for your more kind of folks who have your agitation and your restlessness and a concomitant aphasia. It's using a lot of like visual supports and written supports to be able to help them understand what we want them to be doing in our session and help gain some predictability. So first we're going to go to your room, and then we're going to go outside, showing him pictures to be able to allow him to not only better understand what we're saying, allow him to better express himself, but also help kind of decrease those negative behaviors, decrease frustration, because we're getting him more engaged in the session by having him better understand, using visual supports, what we're going to be doing. And then conversely, for our folks who might have decreased initiation, maybe a little bit more apathetic, even our folks who are in disorders of consciousness, using more kind of cueing systems so that we can start at kind of the most basic level of just expressing your basic needs and wants. So very simply training staff and family on how do we create opportunities for this person who doesn't initiate talking, doesn't initiate communication, doesn't initiate action. How do we create opportunities for them in the most simple fashion to be able to communicate? Obviously, are usually basic visual choices, written choices, those types of things.
So we've talked about some of the ways that you're able to support people with aphasia. I think it's also important to think about what are some things to avoid when you're interacting with someone with aphasia.
Don't miss communication opportunities. You, as a communication partner, making a simple choice or a preference for a person with aphasia when it could have been an opportunity for them to indicate to you what their preference would be. Something as simple as getting dressed in the morning, going to the closet. Do you want to wear, this shirt or this shirt? And presenting both of them and giving them the opportunity to respond. I think what we tend to do as caregivers or communication partners is I think we tend to make the choice or the decision for them and overlook, we don't capitalize on these very, very simple opportunities. What would you like for a snack? Do you want peaches or do you want applesauce? Showing them both and giving them the opportunity to express themselves. So I think it's kind of speaking for them when there's an opportunity for them to be speaking for themselves. Obviously, the obvious one is don't yell. Don't just raise your voice and talk louder. I think another super easy one is we talk too quickly. When you're talking with somebody with aphasia, talk so slowly that it feels uncomfortable to you, because that's how you know that you've made a significant enough difference in your pace, and that is your sweet spot. So making sure that it almost feels a little uncomfortable how slowly you're talking, but what you're doing is creating a platform for them to better process information as well as insert pauses, which gives the person with aphasia the opportunity to process. What else would you say? I'm curious, Alyssa.
I think that is great advice. I would say I'm very conscious about the content of my speech and saying things in a much more pragmatic, simple way. If base level language is a challenge to process at real-time speed, how much more difficult to incorporate figurative language.
High-level language, absolutely. Yep. You bring up a great point. I use the acronym, we need to use big face. Check your body language. Are you standing, if they're not understanding very well what you're saying to them, do you have kind of a closed stance? Are you facing them so that they can see your face? Your intonation, so B-I intonation. Do you sound stern? Do you sound happy and friendly? G, B-I-G, G is use gestures. So pair what you're saying with pointing to your reference, or pair with it maybe a gesture of a drinking gesture or an eating gesture. So big body language, I intonation, G gestures, face your facial expressions. So are you approaching them and have kind of a stern face, a stern an expressionless face, or do you have a bright, smiling, eyes wide open face that's really projecting warmth and that type of thing? So I think for folks who have especially comprehension challenges, check yourself and use big face. All of those nonverbals are so, so important. You're kind of over-exaggerating in a realistic way, but over-exaggerating a lot of what you're doing because that's the message that they're receiving, not your verbal language.
Yeah.
There's this augmentative and alternative communication researcher, her name's Janice Light, and she really kind of boiled down, if you will, the primary reasons that we communicate, and she narrowed it down into really kind of 4 reasons. Everybody, we communicate to express basic needs and wants, or preferences, Secondly, we communicate to exchange information. So telling somebody information about yourself, medical history is a great example. Social etiquette, if you will. The pleases, the thank yous, the things that you show gratitude for, that are all kind of these micro exchanges, and then kind of social exchange. And so it's things like storytelling, being able to sit and have a conversation at the dinner table with your friends and family. And so those 4 reasons really can help guide us and get really specific and pinpoint where we need to start.
Yeah, it makes me think about some of the evaluations, at least standardized, that you can give are just interesting information, but how do you work with that? I'm curious how you go about developing personalized goals for your clients.
Great question. I am a huge fan of goal attainment scaling and motivational interviewing. So making sure that you are first learning about your patient. Tell me a little bit about yourself. Tell me what's important to you. And in that conversation, you're doing really critical active listening to kind of hear, who is this person? What are their values? What are their interests? What's going to motivate them? The guy who comes right on time, wants to get going, and actually doesn't like you asking him questions and gets irritated and frustrated, and then you take a step back and you say, tell me about yourself, and you realize he was in the military, he's a gym rat, and he worked for his family. And so his way is that you show up on time. In the military, there is no asking you, what would you like to do? It is, you tell me what to do and I'm going to do it. And so that is a very different approach that is shaped by knowing the person. Different than, somebody who is a mom and is super agitated from a car accident, and all she wants to do is get the hell out of the hospital, and it's because she wants to be a good mom. And so how do you use that to then shape your goals? And so I think goal attainment scaling, motivational interviewing, and active listening, super critical things. And you can make goal attainment scaling standardized, but really what it is about is the conversation that you have with the person or with the family member, and then identifying where the patient is currently functioning on their own, where they want to be functioning, which may be 2 or 3 levels up. And that's where your therapy lies, right? In between those, what they can do on their own, what they want to be doing, and that therapy is what can they do with a little bit of support from you, and then you work to maintain that, and that's what your therapy sessions are. I think the other thing to keep in mind is the type of therapy that you're doing, what you're trying to address, and making sure you're pairing that with the right patient. So if I have a swallowing problem, or I have a motor speech problem like Aphasia, you better take an impairment-based approach, right? Like we're gonna get in there, we're gonna do whatever, 200 swallows, we're gonna hit it hard. Very much an impairment-based approach. Same thing with Aphasia. Different than somebody who really needs to be able to have strategies for memory or executive function, daily routines, that type of thing. We're not going to take an impairment-based approach with them. We're probably going to take more of a contextually based approach with them. Don't have a mismatch there. My other soapbox is about this idea of functional therapy. We all say that we do functional therapy. Usually what that looks like is we're having the patient do things that would be considered normal for us to be doing. So it might be you're having this inpatient plan a trip to Boston, right? Or work on money management. Well, what we know about traumatic brain injury is that generalization doesn't happen. And so I think there could be a greater degree of emphasis on literally training to the task. And what that means is identifying very specifically what that person needs to be working on, and that's what you're hitting, and you're hitting it hard. we're not going to have the expectation that it's going to generalize. I'm going to teach you this strategy for remembering names, and that strategy is going to help you remember what you did yesterday better. And we use this term, not functional therapy, but patient-centered, contextually relevant. So in the inpatient setting, we want to make sure that whatever we're working on is important to the patient, patient-centered, done collaboratively with the patient. And then secondly, it's contextually relevant. If you think about their current setting just as a context, what's keeping them in the hospital right now? And it may be they can't remember their transfer steps. They can't remember how to safely get out of their bed. They can't remember any of their clinicians' names. Super important to building relationships. I don't know that I see the relevance in the inpatient setting of planning a trip to Boston. They're not going to be doing that. And so why are we not focusing our efforts on things that matter in the here and now? If the goal is they're going to remember to ask their physical therapist a question about themselves to work on social communication, you're always going to be very specific with what you're working on. You're going to engage the patient in the task. You're going to have some type of visual supports. We make a lot of our own materials. We make our own Likert rating scales. We make our own kind of tracking systems, So you can take the components of a more paper pencil type task that there are reasons that people like those, but we can apply those to a more patient-centered, contextually relevant approach. There are these worksheets, deductive reasoning puzzles, which monster lives in which house, what do they eat for breakfast, you got to figure that out. Higher level patients, you start talking to them about fatigue. They're often receiving 5 to 6 hours of therapy a day. Well, now the goal needs to be, we need you to start making the decisions about which things are critical. So let's look at your schedule, let's highlight the ones that are critical, that you have to do. And then there's other ones that maybe you don't know if you have to do or not. And so maybe you don't have enough information about that one. And so then this creates the opportunity to, well, how can we get that information for you to know if you have to attend that therapy session or not? Well, I suppose I could ask my physical therapist. Awesome. Let's set a goal where you're going to track you asking the physical therapist, do I need to attend this session? And then you start making independent choices about which things you come to, which things you don't. And so it's a deductive reasoning puzzle, if you will, in the context of real everyday things, not
you bringing it all back to that providing choices.
Yes,
it's like
yes,
they didn't even know there was like a choice to be made. Provide them that much more involvement in their own treatment and just their routine.
It's about engagement. Yep, it's about building that therapeutic alliance.
All right, with that, we're going to wrap up our discussion into Kim's clinical experience and just her expertise in aphasia, stroke, TBI. Kim, I want to thank you one more time for joining us in the studio today.
Thank you, Alyssa. It's so good to be back here, and I just really appreciate getting to come back here wearing this hat. So thanks for listening.
It was a nice reunion.
Fantastic questions and conversation.
All right, thank you all who listened along to this episode, and we hope we will catch you on the next one. For further information or podcast ideas you'd like to share with us, please reach out at 918-631-2504. And remember, communication is not just about words, it's about understanding, empathy, and connection. Until next time, keep listening, keep learning, and keep communicating.